From the RSNA, welcome to the Radiology Imaging Cancer Journal podcast hosted by the Trainee Editorial Board. I am Yash Singh from Mayo Clinic with my colleagues Brennan and Thomas from Case Western Reserve University and Ghazal from Johns Hopkins.
Today, we'll continue exploring this year's RSNA theme, Imaging the Individual, with special guest, Dr. Joseph Ippolito. Dr. Joseph Ippolito is an associate professor of radiology and the director of the Cancer for Clinical Imaging Research at Washington University's School of Medicine in St. Louis. He also serves as a deputy editor for Radiology Imaging Cancer. He is a diagnostic radiologist scientist who specializes in advanced cancer imaging and runs a research program that advances precision oncology through metabolism, using what is known about the metabolism of subgroups of patients with aggressive cancers to develop imaging and therapeutic combinations that improve outcomes. His unique skill set that combines basic laboratory science and biochemistry, omics, and clinical imaging has led to advancements in two important areas in oncology: characterizing the impact of biological sex on cancer metabolism and characterizing unique metabolism of lethal prostate cancer. Now, on to the interview.
Welcome, Dr. Ippolito, to the podcast. We are so delighted to have you here today. How's everything with you?
Very good. Thank you very much for inviting me. Thank you to the RSNA for inviting me to this very interesting podcast.
Of course, it's our pleasure. So, to start things off, can you tell us a little bit about your background? What drew you from your MD PhD training into cancer metabolism?
Right. So as you know, I'm a diagnostic radiologist specializing in abdominal imaging. And as an MD PhD, I go back many years. And I've always been interested in the interface of chemistry and biology. I think of things from a standpoint of energy, from thermodynamics, trying to understand, why does cancer happen, for example? Does it all come down to energy? Does it all come down to metabolism, for example? Does it all come down to the ability for proliferating cells to require, building blocks as well as energy? And where do they get this energy from? What nutrients can they use? And just the diversity of chemistry and the application of chemistry to cancer biology and just biology and physiology and pathology in general.
Oh, that's really interesting. As you know, the RSNA theme for 2025 is imaging the individual. So, what does imaging the individual mean in modern healthcare, in your opinion? Since your work bridges cancer biology, metabolism, and advanced imaging, it's quite a unique intersection, I would say.
Right. So I think what you're getting at is this idea of personalized medicine, right? And so the idea that every person is unique, every person has specific factors, could be physiologic, metabolic, environmental factors that influence the cancer, but also the response to treatment. And so I think this is something we've got to really think about in the context of imaging and personalized medicine. What we need to consider, this is kind of my point of view, being interested in metabolism. Metabolism is unique from individual to individual, right? Metabolism is kind of a combination of factors that integrate environmental influences, that integrate genotype, that integrate diet, that integrate just overall kind of systems physiology. And when I talk about this, in seminars and lectures, to audiences, I'm thinking, I've got this tumor growing in this patient. So for example, you've got a patient who has a tumor. And so if a surgeon were to cut that tumor out and put it on a bench top and leave it there for days, what's going to happen to that tumor? It's going to die, right? It's going to cease to exist. And so I think that's just an example of how the tumor requires the individual for growth, right? The combination of environmental factors, the combination of circulating nutrients, the combination of diet, and all these other factors to grow and proliferate. And so this is why I think personalized medicine in the context of metabolism is so important. The fact that you've got all these metabolic and environmental factors kind of converging to sustain and potentiate the growth of a tumor in an individual. Are there ways we can personalize this cancer imaging and therapy route to better image, to better detect, and to better treat the tumor on a patient-by-patient basis?
Thank you so much, Dr. Ippolito. So, such a wonderful journey, and your research is quite interesting. So, I wanted to know about how these imaging tools are revealing metabolic signatures that we could not see before. And what can a radiologist now detect that might change patient care?
So talking about how radiologists can image metabolism. And so I think this is kind of a perfect opportunity to talk about how positron emission tomography or PET imaging has really revolutionized the field, right? And so the one trace that we think of when we think of positron emission tomography is fluorodeoxyglucose or FDG, right? I mean, this is really kind of the flagship for metabolic imaging. And we've been doing this for many, many years, decades even, right? And so the fact that it is the workhorse for oncologic imaging tells us that cancer cells need glucose for metabolism. Cancer cells need glucose for energy, and cancer cells need glucose for proliferation. And so we can kind of see this in real time, right? We can give a patient a fluorodeoxyglucose, right, a radiolabeled glucose, and look at it differentially uptake into tumors versus normal tissue next to it, right? The fact that these tumors need this glucose to proliferate and to survive. I think that kind of brings up one limitation of the field as well, because I think with FDG PET imaging, we're kind of looking at this paradigm of kind of bulk nutrient uptake into tissues, bulk nutrient uptake into tumors, right? We don't know what's happening to that glucose. And I think this is really kind of an issue when you talk about metabolism, because metabolism is basically a superposition of hundreds of individual pathways involved in biosynthesis and energy and redox maintenance and other factors like that. We're only kind of capturing one small component of that vast metabolic space, if you will, in the tumor as well as the tissue. And this is why I think we need to think more about radiology as kind of encompassing kind of more diversity in how we can sample and visualize these metabolic pathways in tumors and in individuals as a whole.
Yeah, that's interesting. And totally, I do agree with you. And how close are we to having radiologists routinely incorporate these metabolic assessment into their reports? And what would this look like in practice?
It's an excellent question. FDG PET has been in place for many years. The question is, what other metabolic imaging modalities are we going to try and incorporate into practice? I think this could be a conversation that could go on for hours. So let's kind of talk about PET imaging. So we've got fluorodeoxyglucose. There's other PET tracers that are being used in the clinics, especially a group of tracers called amino acid tracers that are being used for brain tumors. And so we can see that. We can do that right now in the clinics. But, I think in general, there's just an overall lack of metabolic imaging methods that are really kind of widely clinically available. So we talked about PET. Next, we can talk about MRI, right? And so MR spectroscopy is kind of a method that neuroradiologists use to look at specific metabolic signatures in different areas of the brain versus brain tumor, for example, could be important for treatment planning, for surgical planning as well. In addition, MRI, I think, is really showing a very interesting uptick in the amount of metabolic applications. And so, I think there are two very interesting spaces that MR is kind of taking on with regards to metabolism and metabolic imaging. So, number one, we can talk about hyperpolarized imaging with carbon-13, I should say hyperpolarized carbon-13. And really, the major tracer being used here is pyruvate. And so you can use, for example, this supercharged labeled pyruvate, give it to individuals, and look at the real-time conversion of pyruvate to lactate in tumors as kind of a surrogate marker of Warburg metabolism, or what we would call aerobic glycolysis. And so that's been used clinically already. For example, I think there were a couple of studies that showed that if you give patients with breast cancer neoadjuvant therapy and you use this hyperpolarized pyruvate imaging, they can see basically these very rapid changes in metabolism, like within a week of therapy, and predict if they're going to respond to the therapy with complete pathologic response, for example. I think the really important thing about metabolic imaging is that, and this is just a little aside, I think the really important thing about metabolic imaging is that metabolism precedes phenotype, right? So these metabolic changes can happen very, very fast relative to overall changes in tumor size and tumor morphology. And so this metabolic imaging provides a way or mechanism for us to look at therapeutic readout much faster and in real time. And I think this is really one of the powers of this MR method, because on one side, you've got FDG PET that tells you bulk nutrient uptake into tumors, but MR can tell you not only uptake, but it can actually tell you what is that tracer, what is that metabolite becoming. So I talked about FDG PET, I've talked about amino acid PET, I've talked about hyperpolarized MRI. There's another very interesting MR metabolic imaging methodology coming up the pipeline into the clinics called deuterium, DEUTERIUM, deuterium metabolic imaging. And deuterium is basically a heavy hydrogen. And so the bottom line here is that if you have a metabolite or a specific chemical that can be deuterated or labeled with a heavy hydrogen, which is non-radioactive, by the way, you can visualize it with MRI. And so this has been really exciting. Like the advancements recently have been very exciting, where you can give patients, let's say with brain tumors, a glass of deuterated glucose to drink, and you can look at the uptake and metabolism of that deuterated glucose into lactate, into glutamine glutamate, and to other components of the TC cycle as well. I think one of the really exciting things, at least about deuterium metabolic imaging with MRI, is that on one side, you've got hyperpolarized MRI, and really pyruvate has been the mainstay here. And I think it's been limited to, I think, a combination of factors, including instrumentation and the ability to inject high concentrations of pyruvate into the system. But on the other hand, you've got deuterium. And so you've got a much wider or diverse array of metabolites and tracers that you can use to profile metabolism in the individual. And I think this is getting at just the overall complexity of metabolism, as we know, in tissues and in tumors, the ability to rapidly profile flux or change in activity of these pathways across multiple pathways in a given tissue. So we've talked about some metabolic imaging methods with PET, metabolic imaging methods with MRI. So I think these are very, in general, like these could be relatively advanced methods that maybe not every institution or radiologist has access to, especially hyperpolarized and deuterium MRI. Something else that our lab has been working with, and this has been championed by a lot of experts in the field, for example, Dr. Pickard up at Madison, this idea of body composition, right? And so this is with conventional CT and MRI. And I think one of the advantages of kind of this idea of opportunistic CT and opportunistic MR is that we're looking at an individual, right? We're looking at the summation of the individual. Really, this is what metabolism is all about. The techniques I mentioned to you about FDG PET, about hyperpolarized and deuterium MRI, it's all about rapid transient changes in metabolism. But really, in my mind, what CT and MRI can tell you is what is the overall long-term effect of metabolism on the individual, right? We're looking at obesity, we're looking at muscle mass. These are all very, very important components of the patient equation, getting at this idea of personalized medicine, right? We're looking at changes over time, changes over longer periods of time than just with these rapid MR spectroscopy and PET imaging methods. Is it possible to look at muscle mass? Is it possible to look at specific visceral or subcutaneous fat stores in these patients with CT scans and to predict how they're going to respond to therapy? And our lab has done some work with that as well with cancer patients. So it might be possible to combine all these methodologies into one workflow where radiologists could sit down, look at not just the tumor, but look at the entire individual, right? The summation of metabolism across the entire individual with regard to muscle, fat stores, even visceral volumes and bone mass, for example, and be able to basically come up with an equation or a score that says that this patient is going to respond to this kind of therapy or is not going to do so well, or maybe will develop treatment resistance even earlier. So I think this is where we need to go. So to kind of summarize the answer to your question, we've got lots of very, very cool advanced metabolic imaging techniques on the horizon. But what we can do now as radiologists, as a radiology field, maybe we can utilize conventional CT and MR, the workhorses for oncologic imaging, to really kind of squeeze as much as we can out of these imaging methodologies, these technologies, figure out more information regarding body composition and its effect on cancer patient survival, and maybe use that to start to engineer treatment paradigms that are personalized.
So, based on my understanding, you are developing novel imaging approach using PET, MRI, and CT to assess sex-specific metabolic differences in GBM patients. Can you just tell us about a little bit this project?
So I think this is a nice kind of follow-up to the previous question, right? So it's about, number one, the advanced techniques that we've got that we're trying to develop right now versus the existing techniques that we have in our hands already. So we're trying to do both there. So on one end, as I mentioned before, we're very good with carbohydrate imaging with glucose with FDG. We're very good with amino acid imaging with amino acid PET imaging. But really, in my mind, and I think that this has been kind of a source of debate in the community. Well, what about fat imaging? What about lipid imaging? We're very good with obesity imaging with CT and MR, as I mentioned, but what about the ability to look at real-time lipid metabolism? And this is why we're trying to advance some new technologies with deuterium imaging and MR, looking at real-time fatty acid metabolism in brain tumors. And I'll get to the sex differences in about a minute or so. But is it possible to kind of use these new deuterium metabolic imaging technologies looking at lipid metabolism, lipid synthesis in patients with brain tumors, and to combine that with existing CT and MR methods as well? So as I mentioned before, The deuterium MRI gives us this ability to look at real-time metabolism of fat. But, with CT and MR, we can look at the effects of long-term fat deposition with different fat stores, even muscle mass and myosteatosis for that matter. We just published a paper, for example, showing that if you look at myosteatosis, the amount of myosteatosis from abdominal CTs, that can predict outcomes in patients with glioblastoma. Now, going into the sex differences, I think this is important because when we look all the way back to the origins of development, even to the developing embryo itself, it's been widely shown that males are more dependent upon glucose and amino acids for energy, and females are more dependent upon fatty acids. And what we're seeing here in our lab is that these developmental differences in metabolism between males and females is carried over into cancer as well. If I were to profile metabolism or metabolic pathways in patients with brain tumors, glioblastoma, for example, I would see that the male tumors are more likely to be enriched in amino acids and glucose, I should say carbohydrates, and the females are more likely to have certain levels of lipids or fatty acids that are enriched. And so this tells us something very important with regards to personalized medicine. We tend to think that we've got a patient walking into the clinic with a cancer. The patient has cancer X. We're going to treat them with therapy Y. Is it possible that a male with a brain tumor may respond differently to the same therapy compared to a female with the same brain tumor, right? So is it possible that the compilation or the synergy of sex chromosomes and sex hormones could influence the response to a specific type of chemotherapy or intervention for that matter? And this is what my lab is getting at, the ability to kind of look at metabolism or specific metabolic pathways as a way to predict how a male and a female are going to respond differently to a conventional therapy.
So, following up with this, how would this impact imaging and treating GBM patients?
That's an excellent question. So in this paper that we published a couple of years ago, when we looked at the differences in metabolomes between males and females with glioblastoma, we found, just looking at metabolite profiles, that males were more enriched for carbohydrates, amino acids, and females had less of those metabolic pathways. And so, as I said before, we've got all these wonderful imaging tools at our fingertips. For example, FDG PET, even amino acid PET. So I went to my colleagues at Sloan Kettering who do a lot of fluoroglutamine PET imaging, and we said, you know what? If male brain tumors, for example, have higher levels of amino acids, specifically glutamine, in their glioblastoma tumors, is it possible we can see this with clinical imaging using fluoroglutamine PET? And in fact, this is what we did. We looked at uptake of fluoroglutamine PET in patients with brain tumors and found that male brain tumors actually had higher uptake of fluoroglutamine compared to females. So I think this is important because this is showing us not just with respect to like a graph of a bunch of metabolites on paper, we're looking at actual clinical images showing that males have higher bulk nutrient uptake of glutamine into their tumors compared to females. And so if this is the case, then is it possible we can leverage this to look at specific responses to therapies in preclinical models as well? And so, for example, there's one therapy out there called CB839, which is not used very much anymore, but these are drugs that target specific amino acid pathways, for example, glutamine. And so we looked at our mouse models and showed male mice with brain tumors actually responded differently to these drugs compared to the females. And so I think this is an example of how we can use clinical metabolic imaging to inform on potential changes to therapy, right? So in the context of metabolism.
So, moving to the last question, so that we usually ask to every guest. So, like, if you could do one study where you had no restriction, no monetary restriction, no personal restrictions, what would be that research question you would want to pursue?
That's a good question. I think that one thing that we're not doing very well as a field is the idea of imaging treatment resistance and trying to develop new methods to evade treatment resistance that are actually available in the clinical setting right now. So what I mean by that, so I think if I were to do an experiment, I would want to, let's say, take a patient population. We would have males and females separately analyzed, of course. And let's say we were to give our patients a standard of care chemotherapeutic agent, right? So we're looking at standard of care chemotherapy. We look at the evolution of this tumor over time with conventional imaging, PET imaging, even with our advanced MR metabolic imaging, right? As I mentioned before. And we look at the point where they develop treatment resistance. I want to know, in my mind, what happens to that tumor when it becomes resistant to clinical therapy X, right? Can we actually start to then identify specific molecular signatures with our metabolic imaging tools, for example, PET and deuterium metabolic imaging? Can we actually take tissue samples and look at metabolic profiles transcript profiles, genomic profiles, look at how the microenvironment of that tumor is changing over time, and then go to the shelf and say, you know what? We have these specific pathways that are changing in the tumor with response to therapy. What therapies do we have on the shelf right now that we can use for this specific disease? And I think this is where AI might actually come in handy as well. And so we then try that therapy. And then we look at our metabolic imaging technology to identify how the tumor evolves with respect to that therapy. So I think I would want my research to kind of focus more on that, to look at really kind of a pan-omic analysis of treatment resistance and to try and repurpose existing technologies, existing drugs to target those pathways in the tumor.
Thank you, Dr. Ippolito. It was a wonderful time. Thank you so much for your time today.
Thanks for spending time with us today. Special thanks to our guest, Dr. Joseph Ippolito, for his valuable insights. If you're enjoying the conversation, please rate, review, and subscribe wherever you're listening. Your interactions help more listeners find the show. For deeper, evidence-based insights across the cancer imaging spectrum, from screening and differential diagnosis to treatment planning, check out Radiology Imaging Cancer. The link to the journal will be in the show notes. Today you heard from our team, Brennan Flannery, Thomas DeSilvio, Yash Singh, and Ghazal Zandieh. And of course, special thanks to our editor, Kelly Myers. We'll see you next time on the Radiology Imaging Cancer podcast.